Thank you for having me here. Today I'm going to talk about the physiology of the second heart sound and discuss further applications of digital phonocardiography. So first I'm going to talk a little bit about pulmonary hypertension as a basis of our discussion, then use that to talk about potential applications of phonocardiography, a little bit of an overview of the second heart sound, which I'll move through quickly since some of that has already been covered, and then discuss a pilot study that we did applying phonocardiography. And so pulmonary hypertension, just as a way of background, it's defined as high pulmonary vascular pressure due to intrinsic abnormalities of the pulmonary vasculature or secondary causes. There are basically two subgroups of pulmonary hypertension, one being pulmonary arterial hypertension, or WHO group 1, and then non-pulmonary arterial hypertension, or groups 2 to 5. It's progressive and often fatal when untreated. Interestingly, more than 20% of patients have symptoms of pulmonary hypertension for longer than 2 years before it's recognized. And that's particularly the case in those under 36 and those with COPD or obstructive sleep apnea. And so the diagnosis of pulmonary hypertension can be made with physical exam, which can show a loud pulmonic component of S2 or a single S2, along with evidence of right heart failure by physical exam. Transthoracic echocardiography is certainly the key initial test to assess right heart function and non-invasively determine PA pressures. And then finally, right heart catheterization is still considered the gold standard to actually make the diagnosis of pulmonary hypertension. And so in terms of therapy and monitoring, so there over the last couple of decades, many different options in terms of pharmacological therapy, including vasodilators, prostanoids, endothelin receptor antagonists, and phosphodiesterase inhibitors. Common to all of this is patients who often get started on therapy require frequent monitoring, and this is done with repeated echocardiograms. And so this brings up some of the challenges. And so echo is certainly time-consuming, expensive, and you need trained technicians to perform it. And nationwide and worldwide, there's a movement to restrict the use of cardiac imaging based on appropriate use criteria. And so a more accurate pre-selection of patients would save resources and improve the overall quality of care. And so one technique that's ripe for innovation is auscultation. So as you can see here, there are different applications of auscultation. So let me talk a little bit about phonocardiography. Again, this has been covered previously, but it's been around since the early 1900s. The first calibrated form was in 1940. And then Lusada and Aubrey Latham were two of the biggest contributors to the field. And so Latham's investigations in 51 and 54 uncovered the presence of the aortic and pulmonic components in the second sound and traces their production to the closure of the respective valves. And that becomes important when I discuss the pilot study that we did. And so today we're I'd like to focus on the second sound as Dr. Shea focused on the first sound, so the dub in the lub-dub. And so again, this, as Nelson reviewed, is the cardiac cycle, and you can see the different components of the second sound, A2 and P2, and that's what we want to focus on. And so it's just some background on S2. So normally there's a separation of A2 and P2 during inspiration, so it must be at least 0.03 seconds to be appreciated by auscultation. And usually, and this is based on studies done in the 1950s and 60s, it's usually between 0.02 to 0.06 seconds. A2 is louder, even in the pulmonary area, which is the left upper sternal border, by 98% of normal subjects. And usually at the apex, only A2 is heard. A2 also tends to have a higher frequency than P2. So A2 intensity, again, is determined by aortic pressure, the proximity of the aorta to the chest wall, the size of the aortic root, the degree of the valve appositions, and mobility. P2 is determined by the pulmonary arterial pressure, particularly the diastolic pressure, the size of the pulmonary artery, and the degree of apposition of the leaflets. And so then the question is, how do you look at the intensities of A2 relative to P2? And so in patients with mitral regurgitation, for example, A2 is soft, so P2 may appear to be increased. And in ASD, P2 intensities increase and often greater than A2, And that's thought to be due to dilated pulmonary artery and RV dilatation. And P2 intensity is lower in the RV outflow tract if you have obstruction or pulmonic stenosis. And so there are various factors that contribute to splitting. There's this concept of hangout time. So it's the interval between the pressure crossover point and the onset of A2 or P2, which is known as the incisura. It's inversely proportional to the impedance of blood flow in the systemic arterial and pulmonary arterial system. So since SVR is usually higher than PVR, the hangout time is shorter in the aorta, resulting in the aortic heart sound earlier. And during inspiration, PVR declines with further increase in pulmonary hangout time. And so this was touched upon earlier, but there's wide splitting, so you can have hemodynamic factors, increase RV ejection time during inspiration, or anything that increases RV ejection time or causes resistance to RV ejection, conduction disturbances such as a right bundle branch block, LV pacing, or WPW with pre-excitation. You can have fixed splitting with an ASD and severe RV failure, or you could have paradoxical splitting due to conduction disturbances or hemodynamic causes. And then graphically, this is kind of what you see in the normal case, the persistent case, the fixed in the reverse with expiration and inspiration. And so we did a pilot study. The hypothesis is that the P2 to A2 amplitude ratio would be strongly correlated with pulmonary artery pressures. And so as a first step, since there isn't a contemporary reference standard for phonocardiography, our preliminary study was aimed at deriving phonocardiographic parameters in a normal population. So it was a prospective correlation study of a new diagnostic test. So we used an actual prototype of the current Viscope phonocardiographic system. Instead of using a single handheld device, we used 3 microphone transducers connected to an A to D converter and then to a USB port into a laptop to data acquisition software. The inclusion criteria, so outpatients greater than or equal to 18 years old, undergoing echo, in sinus rhythm. Some exclusion criteria were non-cooperative or unable to follow commands, medical emergency, or patients with structural heart disease. So possible predictors, again, the relative amplitude of P2 over A2, the absolute amplitude of P2, the duration of P2, the integral of the P2 component, the length of the split, and also a frequency analysis to separate A2 from P2 using a continuous wavelet transform. A2 is usually higher in frequency. And so the measurements were done simultaneously at the left upper, left lower sternal borders, as well as the apex. We didn't record the right upper sternal border and had a single lead ECG. 20 seconds recordings were done during normal breathing and expiration and inspiration and slightly deeper continuous breathing. And then we use a novel automated detection system to separate A2 from P2 and to quantify the signal to noise ratio. And so the correlations were with echo, using the peak TR gradient as a surrogate for PA systolic pressure. The PI end diastolic gradient were available for PA diastolic pressure, and then the IVC size and variation for RA pressure. And so again, we obtained some baseline clinical variables, as well as a 12-lead ECG where possible. So the preliminary results, which were presented last year at the World Congress on Heart Disease, were for 20 subjects without pulmonary hypertension, 1 subject with pulmonary hypertension, recruited at California Pacific Medical Center here in San Francisco. Only the subjects without pulmonary hypertension are reported here. There was no significant difference in noise across the different positions and across the different breathing conditions. The baseline characteristics, so the average age was 55, more than half of them were women. The peak TR gradient was 24, which was normal. The IVC size was 1.6, all with greater than 50% collapse, also normal. The normal ejection fraction, and then we measured the R-wave to aortic closure of 0.36, which is within normal limits as well. And so during normal breathing, the correlation coefficient of the mean P2 to A2 at the apex with the peak TR gradient was 0.6, which was significant. During deep breathing, the correlation of the same ratio with the peak TR gradient was even better at 0.75. And then looking at all other correlations of this ratio with the peak TR gradient for other auscultation positions and other breathing conditions, it was not significant. And then during inspiration, the mean P2 to A2 at the apex was correlated with the ejection fraction. So then looking at the ratio of the duration of P2 and A2, depending on breathing condition, there was actually a difference between the groups when you separated quiet breathing from end expiration and inspiration and deep continuous breathing, that changed the ratio. However, the ratio of these intensities did not vary based on the position of where you auscultated. And so the conclusion of this pilot study was that in a healthy ambulatory population, the P2 to A2 ratio seen at the apex seems to be the most predictive of non-invasively estimated PA pressures. The components of S2 vary by breathing condition, but not by auscultatory position. And so some of the challenges, differentiating signal from noise. So the microphone position and placement was definitely a challenge in terms of how much pressure do you apply to the microphone to make the recording. There were inherent problems with the equipment at times in terms of making the recording. It was a prototype system. And then validating the method of separating P2 from A2. So that's actually quite a challenge in terms of where does P2 end and where does A2 end, and like how do you actually separate them? And there's lots of things in the literature about doing that, but we use an automated detection system to do it based on the frequency changes. But again, that's based on normal controls in the literature, and it is still a challenge. And then finally, the subject recruitment for this study was a bit of a challenge in terms of finding those willing to participate in the recordings, given the number of positions that we recorded, et cetera. And then finally, those with, I tried to exclude those with structural heart disease, but as we know, hypertension is quite prevalent, and so what to do with those with systemic hypertension, which tends to affect A2, and so that would change the P2 to A2 ratio. In terms of future directions, so first of all, this was a very small study of 20 patients, so definitely a larger sample size would be needed. With the newer generation of the Viscope device, certainly we could leverage that to improve the quality of the recordings and decrease the noise. And then we would need to correlate the findings seen here in a normal population to a population with pulmonary hypertension. So these are all correlated, the TR gradients were normal here. What about those with pulmonary hypertension? Would this still apply? And then finally, the correlations we did were with echocardiography. However, right heart cath is considered the diagnostic standard at present, so what about correlations with right heart cath? And one can envision using the device in the cath lab right before a patient or during the catheterization, which would be a great correlation, maybe perhaps easier to obtain than doing an echo cath correlation. And so thanks to Dr. Schiller and Dick Shah, who helped tremendously with this project, as well as Brian E. Doyle, who did some of the analysis.